Hello. I'm going to ask if we can get started for panel 3. And I'm Tracy Lieu. I'm the director of the Division of Research at Kaiser Permanente in Northern California. I'm a committee member and I'm your moderator for this panel. And just to let you know, this panel is made up mostly of people who have modeling expertise. There is a venture capitalist and, thank you, and others with technical expertise. So let me check who we have on the phone. Is Chris Murray on the phone?
Yes, I am.
Okay, and Chris Murray is the director of the Institute for Health Metrics and Evaluation, University of Washington School of Medicine. Is Peter Hotez on the phone?
Hi, good afternoon.
Hi, Peter. Peter is the president of the Albert Sabin Vaccine Institute and Dean, National School of Tropical Medicine, Baylor College of Medicine. John Boslego. Good, welcome. John is the director of the Vaccine Development Program at PATH. Phyllis Arthur is the senior director of Vaccines, Immunotherapeutics, and Diagnostics Policy, Biotechnology Industry Organization. Come on up and have a seat. Jeffrey Sturchio is a senior partner at Rabin Martin. Irene Ekstrand is a scientific officer, Models of Infectious Disease Agent Study, National Institute of General Medical Sciences at the National Institutes of Health. Timothy Lant is the Director of Analytic Decision Support, Biomedical Advanced Research and Development Authority, Department of Health and Human Services. Is Philip Eckhoff on the phone?
Yes.
Welcome. Thanks for joining. Philip is the research scientist and principal investigator of the disease modeling team at Intellectual Ventures. And Robert Kolodner is a Chief Health Informatics Officer and Acting Executive Officer, Open Health Tools. So this panel actually will work like the earlier two panels. We have about 7 to 10 minutes for each panelist. We'll have some questions and discussion at the end. If you're on the phone, if you could please pick up your handset, not use your speakerphone, and speak directly into the phone and a little bit more slowly than usual, that would be great. Chris Murray, would you like to lead off?
Sure, thank you very much, and my apologies for not being able to be there in person. And I'll just make a few reflections on the basically the strategy here and the prioritization framework. The first observation is I think it's a great idea to try to have an explicit process around setting vaccine priorities, and obviously the history at the IOM goes back to the 80s of this sort of work. And I think it is, from my point of view, the strategy of how you do that, you want to, what are the good attributes that you would want to have, and then to sort of compare that to the proposal that's here. I think one attribute is you want to have a very clear conceptual framework about what are the things that vaccines achieve that people value, and are the things that people value important in their own right. So, for example, improving health or improving other dimensions of well-being, or are they only important because they're instrumental towards some other goal? And I think the distinction between things that are truly valued by everybody in society versus attributes that may only be instrumental or strategic in value is pretty important if you want to have a clear conceptual framework for benefit. And I think, as we'll come back to in a moment, I think that's one of my issues with the current proposed tool. The other attribute you want is you want it to be pretty transparent about how you set priorities, and that at the end of the day, you will end up with multiple goals, let's say health and other dimensions of well-being for vaccines, and you need to have some sort of quite explicit trade-off process between those, and sometimes that trade-off process emerges from democratic discourse, or so that you don't actually need to make that a formal mechanism. but sometimes it can be useful to have those trade-offs, embedded into a tool such as this. And I think those are the two criteria in my mind, and in terms of sort of how you go about priorities. And the third criteria, I think, is, of course, you need to have sufficient data to inform these types of processes. So let me go through those three and make some relatively, my knowledge of the report is just by reading it and a few conversations, so I'm not deeply immersed into it. So I may have missed some of the genesis of how you've ended up with the smart vaccine tool as it stands. But in terms of the conceptual framework, I think the problem I have is that the attributes that are listed and taken into consideration are fundamentally a mix of outcomes that we really care about and things that are just instrumental to outcomes. And I think that's, at least from a personal point of view, not a great attribute. I don't think you want to mix in, does the military personnel benefit from a vaccine, because that's purely instrumental to some U.S. issues, perhaps, as opposed to, what's the health gains and what are the other dimensions of well-being. Or you could go through the list of things that are being proposed as possible dimensions and identify a number that are instrumental. So I think if I were just to react to the components here, I would have said some probably shouldn't be there because they're instrumental and not intrinsically valued as outcomes, or that one would have to be very clear and cogent as to how you separate those two out. And I won't belabor that issue by going through each of the components and identifying which ones, in my personal view, are intrinsic versus instrumental. The second criteria that I mentioned is the notion of how transparent is the priority setting process. And I understood that the genesis of the ranked centroid technique used here was that explicit setting of priorities or trade-offs between dimensions was difficult. But quite honestly, the ranked centroid technique used here is really opaque. And I wonder how many people actually understand what the tool is actually doing by using the ranked centroid approach. It's taking a fundamentally a core trade-off issue for decision makers and burying it in a technique that's come out of engineering that is pretty not really well known in the decision analysis world or in the health or the public health world. And I'm personally not at all convinced that the attributes of the rank centroid approach are things that you want in a prioritization tool. I think it's obscure and not at all clear to me that we're making meaningful trade-offs. So I guess that's my biggest issue with the tool as framed, is the method used behind the scenes to come up with the ranking, even given that maybe some of the attributes, according to the first criteria I gave, might not want to be there. Lastly, on the data front, I think that's a little bit more straightforward. I think while any prioritization tool is data hungry, so to speak, I think that many of the things that you would want to take into account in anybody's approach to this are increasingly becoming available. For example, the country-level results from the 2010 Global Burden of Disease study will, start to be becoming available, and that gives you lots of the types of disease outcomes that you might want. And I think that sort of cost information that probably also needs to go into these types of prioritization exercises isn't yet available, but will increasingly come available as systematized approaches to looking at cost by disease and injury will likely come available analogous to the burden of disease work that's being created. So I think that the good news is that over the next few years, the likelihood of having the rich information base that's required for this type of explicit prioritization exercise is much greater. But I think, to close, I think that the actual way you use richer information to set priorities needs, some fundamental thinking about what should be on the list on almost a first principles basis, and a more transparent and explicit approach to trading off different dimensions of benefit it would probably be desirable. So I'll stop there.
Great, thank you very much, Chris. In general, we're going to hold questions for the panel until the end. But I do want to actually pose one short question to you, and that's about your second point. You mentioned the rank order centroid weighting process that is being used, and skepticism about that because it's not very transparent. And there are some alternatives such as swing weighting or other approaches to ranking or weighting. Are there alternatives that you recommend?
Yeah, I would have thought that which is why my reflections were tied into the first comment, which is I think if you filtered the attributes that you care about by what's intrinsically valuable, you'd end up with a much shorter list. And then I think you need an explicit trade-off type process where people say, look, my concern about levels of health versus equity in health is, you elicit that. My concern about economic well-being versus health is such. I think any of the other sort of voting, weighting techniques are essentially are making those trade-offs implicit and essentially obscuring them. And I think there's no substitute for either a dialogue about what do you care about the most and how do you want to trade them off, or an attempt to elicit from a selected audience their views on those. But that's just my personal view about that.
Okay, thanks very much. Let's go next to Peter Hotez on the phone. Peter, are you there? Are you on mute?
Hello, can everyone hear me?
We hear you well.
Oh, excellent. So I really appreciate the opportunity to be able to speak with you this afternoon. I want to focus my remarks around a specific problem that I had and we had at the Sabin Vaccine Institute with the SMART approach. And that has to do with the types of vaccines that we and others are making targeting neglected tropical diseases. These are a group of around 17 chronic infections. They tend to be chronic parasitic and related infections, which includes helminth infections such as hookworm infection and schistosomiasis. It also includes lymphatic filariasis and river blindness, bacterial infections such as leprosy and Buruli ulcer, some viral infections such as leprosy. And these diseases tend to be very specific for the poorest people living in the world's low and middle income countries. The reasons why I'm concerned about the SMART exercise is that it really stacks the deck against prioritizing vaccines for just about all of the 17 neglected tropical diseases. And there are some very specific reasons that I'd like to kind of take you through that. And I know Chris Murray, if he's still on the phone, we've sort of hammered out a lot of these issues when we were looking at disease burden assessments. So that these neglected tropical diseases and the vaccines that we're trying to make against them, so for instance, the Sabin Vaccine Institute has a hookworm vaccine that's in clinical trials, a schistosomiasis vaccine that's about to enter clinical trials, a Chagas disease vaccine and leishmaniasis vaccine that's in earlier stage, and a West Nile vaccine. And almost certainly all of our vaccines would be deprioritized using the criteria listed in the table. So, for instance, most of the neglected tropical diseases are non-killer diseases. They tend to cause chronic disability, but they don't cause death. Instead, their impact is on their ability to thwart child development, physical development, in some cases intellectual development. They thwart worker productivity, and they also affect pregnancy outcome. So you have then this situation where you're not necessarily looking to avert deaths from neglected tropical diseases, you're trying to avert disability. The problem with looking at, and then you might say, well, okay, we're going to base that then on DALYs or another metric of disability. The problem is there's a lot of controversy into what goes into the impact of neglected tropical diseases on DALYs because of the chronic and debilitating nature of the condition. And that brings us to the next issue, which is that in many cases the database is simply not adequate compared to a lot of other diseases. So certainly for any vaccine that the pharmaceutical companies are interested in, which is just the opposite of our diseases, there's a fairly robust amount of information that could be fed into the inputs for the SMART system. In many cases for neglected tropical diseases, the data is simply lacking. So there have not been, with a couple of exceptions, for instance, we have a demand forecast exercise for our hookworm vaccine, but beyond that, there really isn't that kind of information. So it's completely missing or lacking, and that would certainly have a negative impact on us as well. These diseases generally are not mission abortive problems affecting the military. They tend not to have serious pandemic potential because they don't emerge. They've been there since ancient times. It's just that they've been neglected. There is no financial profitability for most of the neglected tropical disease vaccines. The one exception is possibly dengue, but for all the others, those are the ones we have to take on because the pharmaceutical companies won't address neglected tropical diseases. There's zero profit incentive, so they have to be developed either in the nonprofit center through PDPs, product development partnerships such as ours, and we do that in collaboration with developing country manufacturers. And they tend not to, unless you're in an impoverished developing country, they tend not to have a lot of national security interest, preparedness, and responses. So the point being, something like a Buruli ulcer vaccine or our schistosomiasis vaccine could never rise to the top, and yet we know they're extremely important as life-saving products for the poorest people in low-income countries. So that's a long-winded way of saying I'm quite worried that the SMART exercise is going to stack the deck against a very important group of vaccines.
Thank you very much, Peter. Next is John Boslego, who's the Director of Vaccine Development at PATH.
Thank you very much. I also appreciate being able to provide some comments on the SMART project. I work at PATH, which is a large NGO dedicated to improving the health of populations in the developing world. And we work across a wide range of health interventions, including new vaccine development. PATH does not generate any income, so we are dependent upon donors for the income that we spend in terms of the programs that we work on, including vaccine development. And this money comes primarily from foundations, governments, and some individuals. So for my new vaccine development programs, we're funded primarily by the Bill and Melinda Gates Foundation. We get 90% of our funding for vaccine development from Gates, limited funding from DFID, Research Council of Norway, and the U.S. government. So our priorities for vaccine development reflect the priorities of our donors, which is mainly the Gates Foundation. The top priorities at the Gates Foundation on vaccine development relate to malaria, TB, HIV, and pathogens causing pneumonia and diarrheal diseases. My programs are aimed at pneumonia and diarrheal diseases, especially for applications to infants and young children in the developing world, especially in Gavi-eligible countries, which are the poorest of the poor. So how do we prioritize what we're going to work on for agents against pneumonia and diarrhea? It's mainly strep pneumo, and to a lesser extent, flu and RSV. And on diarrhea, mainly rotavirus, and to a less extent, E-tech and Shigella. These represent the leading causes of childhood mortality in the developing countries. Another factor that we take into consideration is the WHO pre-qualification priority list. So this is a list that's generated by the WHO in concert with input from UNICEF and from Gavi, and working on or looking at these vaccines, which mainly are vaccines that are licensed or close to licensure, helps us to align with which vaccines are most needed for global public health. It actually brings up some interesting selections, such as a very high priority being a pentavalent vaccine. This vaccine includes Hep B, Hib, DPT. These vaccines have been available for decades, but basically the formulation of all of these components into a single vaccine is really what's critically needed by the global public health community in order to broaden coverage. Another interesting selection would be polio vaccines, both OPV and IPV. And while polio causes minimal morbidity and mortality at present, less than 500 cases in 2012, OPV and IPV are really essential for finishing off the eradication campaign. Now, one might say that all we need is increased capacity for these vaccines, but that actually isn't the case. In the terms of OPV, there's a really high priority being set on bivalent OPV. And also for IPV, this is so restrictive in terms of where one can manufacture it that there really is not sufficient capacity for IPV made from Salk, nor could there be in the foreseeable future. So in order to get IPV amounts that are needed for eradication, one is going to have to be looking at different forms of IPV, which is clearly vaccine development. So in terms of the specific questions on usefulness, this is not of immediate, the tool would not be of immediate usefulness to me, since my priorities are set really by donor organizations. I'd be really quite interested in test driving the system to see, for example, how a new rotavirus vaccine or a new pneumococcal conjugate vaccine might stack up against other vaccines in the prioritization list. And if we're working on new rotavirus vaccines and new pneumococcal vaccines because of issues of cost and availability, and because these are vaccines of such high priority, although they do exist, we need more of these vaccines. So in terms of usability, I believe this is a great selection of attributes in the system. The one that is not captured is availability and capacity of a given vaccine. And again, this relates to my comments about what's needed by Gavi and by UNICEF and so forth and so on. We don't capture where there be shortages. Maybe that isn't a particular need of this particular tool, but if it's not, then the tool probably is more germane to vaccine development rather than, a new vaccine development rather than vaccines that are already available. In terms of data library, this has been mentioned before, but I'll just increase the, the need for disease burden data, particularly in the developing world. We have fairly good recognition of pneumococcus and rotavirus as acceptable global pathogens, but others for both respiratory diseases such as flu and RSV, or for diarrheal diseases of E-tech and Shigella, these data are really lacking in the populations of interest to us. There are surveillance systems being set up to capture some of that, but the data are not here yet. We even took a look, I know Group B strep is one of the vaccines of interest to the committee. We actually took a look at Group B strep surveillance and disease burden a few years ago. And although there was data from South Africa and the US and Europe, we had a great deal of difficulty finding data in other parts of the world. Another issue on data availability relates to predicting the impact of vaccines. I think the impact on herd immunity, what's been seen on rotavirus and PCV and others are very, very difficult to predict during development and really require that these vaccines be available in the marketplace for quite some time. We can talk also about the issues like strain shift for pneumococcus, again, very difficult to predict during development. And a final example would be the durability of protection of acellular pertussis. So the reasons for the continued outbreaks of pertussis in the US and elsewhere, particularly in terms of the use of acellular pertussis, are difficult to understand and certainly could not be predicted during the development. So in terms of application development, I would like to test drive the system, but I have no recommendations at this time. And lastly, on outreach, I think similar to the comments that have been made by the colleague from Iowa and the WHO, it would be interesting to take a look at this system by ministries of health in developing countries. They have to deal with prioritization of vaccine introduction in their countries. A good example would be rotavirus versus pneumo. Some of these countries are actually making those decisions. It'd be very useful to see how this tool might assist them in that discussion, or even take a look at some countries that have prioritized one versus the other and see if this tool will actually support that decision making. Thank you.
Thanks very much. Phyllis Arthur.
Good afternoon. Thanks so much to the committee for inviting Bio to add our comments to the comments of this illustrious group and the ones before. I'll try to condense a lot of things. You heard from several great industry folks beforehand. Just for background, Bio is actually a trade association that represents about 1,100 biotechnology companies in food, agriculture, and health. I work specifically with both current manufacturers of vaccines as well as those developing new vaccines, and mostly based in the US and Europe, but some internationally. I wanted to just start by talking about the usefulness of the smart vaccine system. I think many of my colleagues in industry feel that the smart vaccines program actually could help government, non-government, and certainly commercial enterprises reach consensus on what's important and what the priorities might be. It could certainly help provide guidance to the grade and ACIP process, which is very important to many commercial enterprises in the United States. But it definitely needs to take into account the timelines for developing vaccines. And so that discussion that Dr. Gellin had at the beginning about how often we look at this process is very pivotal to industry, because you're obviously making go, no-go research decisions at phase 1, 2, and 3 in development. And it's important to know when those reviews are going to take place and how they may shift investment by industry over time. So that decision on how often the projects are reviewed, how often we look at the prioritization lists, will be pivotal to industry's investment timelines and should be done in a way that is relatively in concert with the development timelines of vaccines overall. Vaccine companies obviously use their own unique internal prioritization programs. You heard the ladies from GSK and from Merck in particular talking about looking at your whole product portfolio, looking at across the scientific expertise you already have. I think you heard that from Dr. Hetherington. If you've already got a platform that that is your base of your business, you're going to need to look for antigens and pathogens that match that platform. So a list will be helpful, but only so far. And there are these other factors that probably could not be included into a model because they're specific to the commercial enterprise that's looking at the decisions. So there needs to be some overlap where industry may indeed use this, but probably in a way best to understand and inform their internal process. Hence why you'll hear industry say quite a bit about understanding transparency of the data used and how it's going to affect key decision makers' decisions, because the probability of those decisions factors into the decision to invest at the company perspective, at the company level. So certainly companies may use the model to inform their discussions with government. They may use it as a part of their internal prioritization process. They also may use it to try to understand the probabilities of success in terms of certain policy areas, the decision to cover, the decision to add it to an existing program, or which priorities in terms of, say, accessibility, feasibility, acceptability should be factored into the development program of each individual company. So it's very important to have that transparency in the choices, particularly by payers or decision makers, as that to some degree has a back and forth relationship with the development process. If the biggest payer says doses are the most important thing, the number of doses over populations, everyone has to understand how those two things interact with each other in terms of driving the development program. So in terms of usability, I think we talked about that a little bit. This transparency, I can't stress it enough. I think because we've talked a lot about the data and the variability in the types of data, the variabilities in the levels of validation of said data, understanding what data was used to, even if it's just decision support, what data was used in the model, and why certain attributes were chosen by the user of the model are very important. The very nature of actually picking 4 or 5 of the 29 attributes needs to be well explained so that someone can understand why 1, 3, 5, and 9 were chosen over others, and then in addition to that, what data was used to fill that in once those attributes were chosen. Especially since we discussed earlier, different types of users will develop different kinds of lists. So in our industry, we certainly work with BARDA, we work with DoD, we work with WHO, work with the CDC. Understanding this part of the attribute selection process for each of those customers will be pivotal. On the other hand, it's very important for those who are choosing the attributes and running the model to understand that companies cannot necessarily develop 17 different vaccines in the same therapeutic area. So the consensus building process across those different stakeholders will be helpful in terms of maximizing company decision making. I mentioned the long development timelines. I think that's really an important one because companies are often very well invested into phase 2 or phase 3 when something may happen and the priorities may shift. This has a very important and can be negative or very positive impact on the investments the company is making. And I'm glad we're going to hear from some people in the investor community who are also looking at those changes and deciding where to invest their funds as well. I think one of the unintended consequences just to think about, and it may not be one that can be solved by the model, is that no matter what, once lists are derived, they could have unintended consequences on funding decisions by a host of different funding sources, be they Gates Foundation, investors in Wall Street, or companies themselves. And so it's just very important to understand that the lists need to be clear and they shouldn't cut off funding for projects that don't necessarily make the list but may end up being important emerging infections in the future. Flip my page here. The data library, I think everyone's discussed this a great deal, and it's obviously of concern to every stakeholder. I think that the quality of the data used is going to be pivotal for this to really have a robust decision support mechanism. There might be a couple of different ways to get at the quality of the data. I heard several different panelists mention creating a database that's searchable. I think that's something that would certainly be of use. I think that it's important for stakeholders to encourage all the stakeholders to publish in the different data they may have, be either from clinical trials or from academic work or disease surveillance data. It's also important, one of the data sources we haven't heard actually mentioned before, besides surveillance data, which is pivotal, is actually data on accurate background rates for various AEs. So it's vital, obviously, in terms of making that risk-benefit ratio, to have excellent data on how much regularly occurs for Guillain-Barré, someone mentioned before, other particular sequelae, so that there's a good opportunity to look at products as the clinical development program proceeds and see that you're not seeing something alarming or you are seeing something alarming. And those background rates are pivotal to part of that decision-making and prioritization process. So that's another source of data that is of great importance. I think we all agree that the gold standard is published scientific, observational, experiential, or clinical data, and that should be encouraged as much as possible. And actually, it may lead to a need to weigh the data, which I think was suggested by the panelists from GSK. And we had thought about this as well and felt that perhaps it might be good to value score the data. I think that was what was suggested by Genevieve earlier. And that can actually shift over time as you get closer to more clinical data. The weight of efficacy choices and so on, side effects can be given more weight as it becomes truer to actual reality versus desired product profiles very early in phase 1 or 2. So I think the other thing is this need to actually have the opportunity to trade off. And I think that's pivotal because decision makers are going to have to choose between an optimal product profile, let's say only 2 doses with lifelong immunity and thermal stable. That might be, from a feasibility perspective, 10 more years of research. On the one hand, that really helps to identify the gaps in our science to solve that problem, but that hopefully wouldn't mean that you wouldn't go through the iteration of actually maybe having a lesser desired product in that therapeutic space in the short term. And that's exactly what companies do. They might make a product that's a little less of the perfect, get it out there, get the experiential data, and then move on to iterate to the next level. So the model needs to be able to allow for that iterative best case and cases in between and look at the value of those. In regard to outreach, I know that the companies that are a part of the bio-vaccines working group are definitely looking forward to getting their hands on the actual system, and especially looking forward to interacting with varying potential users, be they payers or be they governments or non-governmental organizations, to see how they go about using this and to get a little better experience with how the data choices are made, both as companies look at it as a resource for themselves and as they look at how governments will use it. I think when you look at what might be tested in the next wave of tests, I heard some great ideas today. I think that an emerging disease where we can really get an experience for where the gaps are in data would be a very good test to see where there might be gaps to fill for something like a norovirus, something that's new like a norovirus or something we haven't seen everywhere. Trying something with a different population than just peds, something that's adult or something that's hospital-based would also be useful, as a lot of the future products being researched now are a little more niche, and I think that it would be very important to look at something that's got a little bit different market base than just straight pediatric or adolescent. Anyway, we really look forward to the rest of this process. I think you'll find industry to be very willing to help look at it, help look at what data sources make sense, and try it out. Thank you.
Thank you. Jeffrey Sturchio.
Well, it's a pleasure to be here this afternoon to add my perspectives to today's intriguing and wide-ranging discussion of the Smart Vaccines Decision Support Tool and its potential utility in setting priorities for the development of new vaccines. One advantage of coming late in a program like this, replete with a wide range of feedback, is that I've had the advantage of learning from the 24 experts who've preceded me. A concomitant disadvantage is that almost everything important has already been said, but it hasn't yet been said by everyone. So, but with that in mind, and I'll try not to be too repetitive, I'd like to offer a few comments on 3 of the key questions for discussion. Before I do that, I just want to give you some sense of where I'm coming from. I've had a variety of different roles in my career. I began as an academic, and I still have an interest in academic policy analysis. I spent nearly 20 years in the pharmaceutical industry, and then a couple of years as the leader of a major NGO involved in policy and advocacy for vaccines, among other issues. So I have a fairly broad perspective on the issues that we've been discussing today. So with that, let me just address usefulness and usability together. Since I haven't had a chance to use the decision support tool yet, it's difficult to judge precisely how user-friendly it is. But the Blueprint report, which I did read through, is clear both on how the interface works for different users and on the limitations of the attribute scoring. And we've heard a lot about both of those examples, or both of those aspects today. What I found most useful in the Smart Vaccines model was its thorough review of the wide range of considerations to take into account in addressing vaccine development priorities. Some have argued there's little new in this analysis and that it provides a level of spurious rigor in balancing many competing, sometimes intangible factors that are inherently difficult, if not impossible, to quantify. But I found this wide lens valuable in spurring more systematic thinking about the challenges of setting priorities for vaccine development, particularly in broadening the focus beyond the usual health, demographic, and economic factors, to review in the same process a wide range of public policy, scientific, business, and programmatic considerations. So that breadth of perspective and the flexibility of the model in allowing users to assign different weights to different factors is both a strength and a drawback of smart vaccines. The drawback is that, as indicated in pages 61 and 62 of ranking vaccines, the more attributes that are included in the model, the more the weights of subsequent attributes are so small that they're, quote, extremely unlikely to affect weights meaningfully, unquote. So what this means in practice, I think, is that decision makers will need to fall back on other considerations for making their priority decisions. Smart vaccines can only provide directional guidance, as it was designed to do. So several speakers have made a similar point earlier today. I'd also observe that, from my perspective at least, setting development priorities in the end will need to move from the theoretical weighting of vaccine attributes to the practical realities of whether desired vaccines are technically feasible, able to be manufactured reliably and economically, and likely to be licensed successfully in a timely way. So, for example, few of us would argue about the desirability of having a safe and effective HIV vaccine to help prevent the further spread of the pandemic in vulnerable populations. And smart vaccines would undoubtedly score this highly among potential new vaccines. But it's precisely the difficulty of the underlying science that has kept this prize beyond our reach, no matter how highly we score this attribute in a decision support tool. Now, in terms of outreach, the other question that I'd like to just briefly consider, with that limitation in mind, the one that I just mentioned, let me suggest the importance of providing guidance to users of smart vaccines on how to engage a range of stakeholders in dialogue around vaccine priorities as an indispensable element of the process. Again, this has been mentioned in different ways by some of the previous speakers. But just as the IOM, to its credit, has been deliberate in seeking broad input and being responsive to the feedback obtained, potential users of smart vaccines should emulate this behavior. The best way to address the inherent uncertainties in assessing many of the attributes included in the model is to use it as the basis for a robust discussion of the trade-offs inherent in any ranking of vaccine priorities. By structuring such a multi-stakeholder dialogue as part of the process of using smart vaccines, users will be able to develop what ranking vaccines says is, quote, a common language for determining priority areas of national and global interest, unquote. So enabling those conversations, informed by the different rankings that smart vaccines can generate from different user perspectives, and establishing common ground in assessing vaccine development priorities so that there's a convergence in the discussion around what those priorities should be, those seem to me to be perhaps the model's most useful contributions. Thank you.